orthokeratology with you and try to help you along with your staff to be able to practice this treatment successfully, because as you can imagine, it's really all about topography. Here are my disclosures. I have some interests in this area of corneal topography. Okay, so who is the most important person in your practice related to ortho-k? The most important person in your practice. You know, is it you? Is it the technician? And I would argue that it's the person taking the topographies, whoever that is, be it your technician or you, but the most important person is the one that's in charge of doing that capture of each one of those maps. Now, why is that? Because corneal topography determines the candidacy. Of course, the RX determines the candidacy too, but you know that. The topography is something you have to take to understand, is this patient a good candidate for treatment? So that's the first thing that topography does for us. Tells us if this is a good or bad candidate. The next thing is, and maybe the most important thing, it determines our initial starting point in ortho-k. Be it a empirically ordered lens, a trial fit, inventory, using third-party software, whatever it is, you're using that topography to begin in ortho-k. So if your map stinks, then you're off on the wrong path, and that's no good, right? Because it's adding a minimum of 2 extra visits to you. So if you do it right the first time, you're reducing the number of refits, the number of return visits. Finally, what topography does is it tells you if you've done it right or if you've done it wrong. And understanding these post-wear maps is critical to your whole treatment in general. You know, that's one of the first things we're going to do post-wear is do the subtractive map and figure out, did we get a bullseye? Did we get a smiley face, frowny face, central island, or lateral? And all of these maps we'll go through this afternoon. Okay, so I've taken my topography. Here it is. Would you trust this map? Is this a good corneal topography? And man, this one is a mess. Yeah, it just doesn't look smooth at all. We've got hot spots next to cold spots. We've got small fissure. There is a lot of bad about this topography. It's just not smooth. And as an example, we normally expect to see a nice figure 8 or hourglass astigmatism, and this one has both a central steepening, but then at the lower lid margin, you've got that horizontal flat spot, right? So there's a lot of bad in this one. I want you to go a little bit north, just to the lid margin. Do you see that blue area of, let's see if, whoops, let me go back. See if I can find my pointer. This spot right here. You see that real cold area that's right at the lid? That's totally false data. And if you were trying to build the toricity for this eye, you wouldn't have a clue what's there because there's just bad information. If you look at the data from this topography, the Ks aren't completely out of whack, but I want you to look at the eccentricity. Now, eccentricity is a measure of the rate of corneal flattening of the eye. And a normal, disease-free, healthy eye should have a rate of flattening about 0.65 to maybe down to 0.5. And this eye has a 0.63, so normal, but what isn't normal is the eccentricity of the steep is higher than the eccentricity of the flat. That just never happens, or it rarely happens, that your steep eccentricity is a higher E-value than your flat. So right off the bat, that tells me something's wrong. And you can look at the disease detection indices, and one of them is green, but the other 2 are yellow, red, so that's saying suspect, and this is an absolutely normal eye. So what I'm getting at is we really have to be super critical of these baseline maps, because if we get it wrong, we're off on the wrong path. And as you guys know, we're going to send the patient home with the lens, so we're doing a pre-fitting assessment, then a post-fitting assessment to find out that things went wrong, and that would be an utter waste of time. Now, in the post-wear, of course, both the baseline and the post-wear map are important. If you had to make an assessment of this outcome, what would you say? Is this bullseye? Is it the target effect that we want? Is it central island? Do we have this area of reduced effect? It's not a true island, but nothing going on, it's green. Is it a are we waiting for something good to happen? We really don't know what's happening here, and it's because my post-wear map really stinks. So again, the topography is so important. Here's another one. You've got this cold spot right next to a hot spot. That doesn't happen in normal eyes, and it doesn't happen after orthokeratology. Ortho-k uses that tear layer profile, that fluid layer, to create compression and suction on the surface of the eye. We don't get these massive shifts in the curve or elevation of the eye. So this is an utterly poor topography. And if we put it into a subtraction, you see that it appears to be a bullseye. The blue treatment zone is kind of well centered to the pupil and the visual axis, but there's this island. Is that real or is it false? So again, we have to be critical of our captures. Now, if you're at boot camp, I'm assuming many of you are new to ortho-k. Maybe you haven't even started in ortho-k. You need to get a topographer. And the story is any topographer is better than no topographer. So as long as you've got one, you're ahead of the game. You can consider topography to be essential instrumentation in this treatment. You've got to have one. Which is the best one? Each one has different strengths, so it may depend on your practice. Is your practice a little more surgically oriented? Then that may be a specific instrument for you. So you do ortho-k and you're doing a lot of disease work, then maybe it's one topographer. If you're utterly specialty contact lens, it might be a different topographer. So related to ortho-k, what should you use? I might suggest to you, talk to the labs in the exhibit hall. If you've chosen a design, they may favor a specific instrument that seems to be the best tool for working with their system. So that is a way to go, and certainly talk to your colleagues here. There's so many experts that have tons of experience, many of which have had every topographer. So that's a great way to get understanding of which instrument should you use. Okay, so you've got this capture. Is there anything wrong with this image? And of course, we've got lid and lashes blocking a good percentage of the iris. And then look at the eyelash shadows that you can see right down here. They're making it past the midpoint of the eye. So all those eyelashes are blocking data from getting back to the instrument. So get those lids and lashes open as much as possible. Now, I know we're imaging mostly kids. They may have eyelashes that are pointing straight forward. They're going to be tough, but do whatever you can to get that out of the way. As an example, just pulling up on the eyebrow, if your topographer is right in on the orb, just reach up and pull up on some skin, and that'll get a little more information. You can have the patient pull down on their cheek, just a hair, to move it out of the way. You don't have to have them drag it down, but anything to open up the fissure and get more information is, our goal. Here we've got issues with both the lids and the eyelashes, and it's creating a massive shadow up here where there's just no data. And we've got to get information there, because if this is a width rule cornea or a spherical cornea, we need to understand the shape of the eye vertically so we can choose the appropriate depth of lens for that axis. So it's not just the horizontal that matters. We want both meridians so you can build the appropriate shape for the two principal meridians of the eye. This one has almost everything going wrong here. We've got the lids in the way, we've got massive eyelash shadows, and we've got a big tear wedge here that, notice the rings just disappear. They're moving sort of horizontally, and then they just kind of move vertically. They're just gone. And that's just hitting the lacrimal lake down there. So again, just pulling down the cheek could get rid of that lacrimal lake. You'd get a little more information. So if you're not doing the topographies, you've got to teach your technician to be utterly appreciative of the fact that their job determines the success of this treatment right up front and determines the success long term. Now, one of the things about a reflection-based topographer, and that's the vast majority of topographers out there, it's reflecting off the tear film and back to the instrument. And what you're looking at is the tear film dynamically. And what you see is that this eye has tear film breakup. And of course, with kids, we're going to see less of it, but anytime we are imaging a patient and their tear film breakup is measured in milliseconds, then that creates potential for there to be error. So here, you might look at this map and say, this is okay. We've got some eyelash shadows here. We've got some shadow from the lower lid here. But the rings, do they look parallel and even to you? Well, one of the things you want to do is zoom in. And any rings, especially in these first 10, could potentially ruin the entire topography. What the instrument does is it starts in the center, and it considers that sea level right here. And so if you want to measure the height, the shape, the whatever, it has to start with an understanding of the sea level. So if your central rings stink, then potentially the rest of the topography is utterly useless. So be really critical about those central rings. Have your technician, if it's not you doing it, make sure that they're zooming in and ensuring those central rings look really good. If they don't, get the patient to blink more frequently, or in a worst case, we put in artificial tear. And we don't want to load up the eye with fluid and shape that isn't really there, but if you can't get a capture within a couple seconds, then that's what you got to do. So here's a capture. Notice that we ask the patient to blink just before we start. We try to get a capture within 4 seconds. If we can't, then we're going to ask the patient to blink again. We're going to try to do it all over again. So we're going to take that capture after a couple blinks, then within 4 seconds. If it's not within 4 seconds, if we can't center the unit, then we're going to blink again and start over, then zoom in and make sure those central 10 rings look good. That's the usual procedure. So again, if you can't get a capture within 4 seconds, then the tear film is going to start breaking up and you're going to have topographical error. So make sure that the patient is blinking regularly so that you're ensuring a smooth and even tear film. Here's the same patient, one obviously with the fissure fairly small and the other open right up. You see the trouble with this capture here. We've got all of this lid coverage, the eyelash shadowing, the tear wedge down here. Do the best you can to open that up. It's going to be tough with kids, and there's no doubt that they're some of your biggest challenges in capturing topography, getting the fissure size open, but do the best you can. I've heard of tools like having a eyelash curler by the topographer, and when you really need it, you pull it out and get those eyelashes out of the way. Maybe an extra set of hands when you need it to move those lids out of the way. So do what you can. What do you think of this capture? This is not a normal looking topography, right? It looks like superior keratoconus, and there's a channel right through the astigmatism of the eye, a flat spot. And that's going to adversely affect the construction of the lens. What do you think, what kind of fit do you think would result from us putting a lens on this bad topography? We think the eye has this central divot, this central hole, this flat spot. So when you construct the lens from data on this map, you're going to think you need a flatter lens when really you need a much steeper lens. So you may have central staining, you may have a lens that's crashing in the central epithelium, you may have a lens riding high, just not centering well. So we got to take a better map. And this is what the real shape of that eye looks like. So you can see how much topography can lie to you. It's constantly needs to be assessed for whether it's cheating. And it's just a dirty, rotten scoundrel when it comes to topography capture. So you just be super critical. Take multiple maps. That's how you can tell, is one possibly false? So related to that, how many maps should we take in ortho-k? When you're about to begin treatment with a patient, do you take just one? And the answer is absolutely never take one topography. If you get the map wrong, let's say your technician takes the topography and then you see it later, patient's gone, and you've got this crummy topography, now you're hooped. You got to either bring the patient back or start with a lens that you expect will be wrong. Well, don't take one map. Always take a minimum of 4. I personally take 8. I want a massive amount of maps so that I can start from the best one. If your instrument allows you to merge them together or create a median, an average of them, then that would be helpful too, something like a composite. But take multiple maps. That's the key to having successful outcomes. Now, what about post-wear? If you take 4 baseline, how many should you take after treatment? And the story is, take a minimum of 2. Ideally, when you're first starting in ortho-k, take 4. And that way, if one of the maps or 2 of the maps is erroneous, you can throw those out and use the other 2. As you get better and better at recognizing good from bad topography post-wear, then you only really need 2. But never take just 1. Take at least 2 post-wear. Now, which one is more important? If you were to encourage your technician to spend the time to capture maps, which one is it more valuable to put in that extra time and effort? And really, when you compare ortho-k post-wear, you're always referencing what the cornea was. You've heard a little bit already about using a subtractive map. This is your best tool in ortho-k to understand what's happening. You're always referencing what the cornea was in the start. So your most important map is your baseline map. Take the time on that one, because there's going to be multiple visits. You're going to keep seeing the patient. You're going to constantly have post-wear maps. So you're going to have lots of post-wear visits. But you will only ever have one good baseline map, or the opportunity to take one good baseline map. Otherwise, if you wash a patient out of ortho-k to get a good map to start over again, that could take weeks in ortho-k to normalize the eye. So spend the time to get a really good baseline. That's one of the strongest encouragements I can make for you guys. Okay, now you've got this brand new topographer. It assesses the topography, the data, numerous different ways. And if you were like me, you were maybe very intimidated by what the instrument was giving you. It had all of this information. I can select this analysis, and which one do I use, and why do I use it? It's very confusing. An axial map is for understanding power. An axial map is to understand vision. So if you want to understand how the anterior surface has changed in shape and how that will influence the patient's vision, it's an axial map. If you want to understand shape, where you've altered the eye, then you use a tangential. So axial for power, tangential for shape. Those are the 2 critical analyses that you'll use. Now, if any of you are doing your fellowship in the AAOMC, then you've probably been encouraged to read the orthokeratology textbook by John Mountford, and it references using 3 maps: axial, tangential, and refractive. Refractive tells you the size of the treatment zone. It also tells you the power that has resulted. But an axial and a refractive map look so similar. So I would just use axial and tangential maps because, again, the refractive looks so similar to an axial. Okay, so post-wear, we're going to do this analysis. And this is one that we're going to spend much more time on this afternoon because there are numerous different outcomes that happen after ortho-k. And this is really important for you to understand these subtractive maps. They're key to orthokeratology. The axial map gives you lots of data: the RX change, the treatment zone size, the treatment zone position, the myopia controlling signal. So you get a lot out of your axial map. The tangential map tells you only one thing, but it tells you one very valuable thing. When the patient closed their eye over the lens at night, where did the lens position? So you use the 2 of those analyses to appreciate this whole plethora of data that you can collect from the maps. Now, we're going to talk a lot more about subtractive maps this afternoon, but I just wanted to introduce it a little bit. A subtractive map is hard for people to get their heads around, and I know this because I've seen numerous speakers that are world famous at specialty contact lens use only a post-treatment map by itself. If you don't use the subtractive map, you don't know what's changed. You can see in the baseline map what the cornea was. you can see in the post-wear map what the cornea is, but you can't merge together what's changed. That's the subtractive map. It tells you what's going on. So here is obviously our baseline map. There's our post-wear map. All the thousands and thousands of data points that you have in A are subtracted from B to give you C. So what you're looking at on the right, and it's literally the right-hand side of every topographer that does a subtraction, it tells you blue is where you've flattened the cornea out, where you've had myopic reduction. Red is where you're pulling on epithelium or where you're steepening the cornea. So we use these maps to understand how we've altered the eye shape. If you take nothing away from my talk today, take this away, that you need to figure out how to use the subtractive map when you get home. Okay, maybe take two things. Number one, take good baseline maps. Number two, figure out how to use the subtractive map. It's so key to helping you along your path of determining what do we do next with the patient. Do we stay in the same lens or do we refit? And if we refit, do we tighten the alignment zone? Do we loosen the alignment zone? Do we raise the reverse curve? You know, there's so many things you can do in an ortho-k lens. It's much different than conventional corneal GPs where we might steepen the base curve or flatten the base curve. We might go larger or smaller. But with an ortho-k lens, there's many things you might do. You might alter the base curve, you might change the reverse curve, you might change the alignment zone, you might change the toricity, you might change the diameter. So you must know what's happening with these post-wear maps. So here's your axial subtraction. Baseline map, post-wear map, subtractive map in axial interpretation. And what did I say axial tells us? Power or shape? Power, right? Axial is for power. Axial is to understand vision. So when I click my cursor right in the center, I can look down here at where the cursor tells me the net power change. It's 1.97 diopters. I know you can't see that in the back. But essentially click your cursor right on the center of the map on the visual axis, and that will tell you the refractive change you've created in ortho-k. You don't have to do a refraction. You can just go to your axial subtractive map. Look at the blue-green treatment zone, the border of the light blue here where it meets the green. Green is basically zero effect. Nothing is happening. Blue is obviously flattening. Yellow is obviously steepening. So the blue-green border tells you the size of the treatment zone. And then using that same border, where is the treatment zone in relationship to the center of the map, the visual axis, or the pupil? So really important analyses, and we'll also talk about how you assess the myopia control signal this afternoon. The tangential map is opposite. You ignore the blue in the center. You don't care about the blue in the middle. You actually concentrate on this red ring here. That's where your reservoir is in your ortho-k lens. That's where the fluid layer is the thickest, creating the greatest suction force, pulling on the epithelium. So you know that your ring, your reservoir is concentric, so we should see a concentric ring running all the way around. What's the next zone in the lens? You've got ortho-k lens that's close to the cornea in the center. Then you've got that reservoir of fluid, right? What's the next zone you see in the fluorescein pattern? The alignment zone, right? And the alignment zone creates this blue flattening that you see here. So going back to an axial map, we are ignoring almost completely everything that's happening out here. We're concentrated right there in the middle. In a tangential map, it's the opposite. You're ignoring everything that's going on here, and you're concentrating paracentrally at that red ring and the blue ring. They're going to tell you where the lenses are centering. Now, when we get into the afternoon session, we're going to learn about the ideal and the adverse outcomes. And there are really 5 that are defining virtually everything that you need to alter in ortho-k, or not alter. So the bullseye is the target of treatment. That's a well-centered blue treatment zone. The smiley face is where the treatment rides high and you get a smile, a hot curvature just inferior of center. So it's riding high, giving you that smile. The opposite would be if the blue treatment zone rides low and you get your paracentral steepening up top. That's an inferior positioned lens. Central island, you don't see too many of these, thankfully, but what it means is the lens is a mile off the eye surface. It's creating a suction force in the center. It's pulling on the central epithelium rather than compressing the central epithelium. Then the final one would be lateral displacement, and this is one that's hardest to resolve, but we'll talk about that this afternoon. Thank you to the Vision by Design for having me, and thank you very much.
So we're going to get a little bit more from Dr. Kojima after lunch. What we've got now is we've got a break for about 25 minutes, and then we've got some lunch and learn type breakout sessions. So when you look on your agenda, you'll see that there's some breakout sessions from different vendors with different speakers, and those are lunch and learn. So kind of pick one out that you think fits what you want to learn about, pop in there, get a little bite to eat. We are going to be back in this room at 2 o'clock for part 2 of Dr. Kojima's topography lecture. And then at the end of that, there may be a little bit of time for questions if you have any for him on either part.